go with that. Okay. All right. Is there sound now? Thank you, Debbie. There's no sound. Is there any sound now? We're taking the AirPods out. Okay, is there sound now? Debbie, thank you very much. Okay. Uh, all right, so let me just cover what I just said. That was a whole lot of stuff. I'll be brief. Uh, um, Gosh, there was a lot of stuff there in the intro. I should have watched that question mark a little bit sooner. I'm going to pull it up so that I see it again. Okay. Um, the number one, two things. This is an analysis with cone beam CT scan used for articular analysis. Articular analysis was developed primarily by Dr. Blair back in the 60s, so it's quite dated. He was using plain film x-ray, then we moved to digital x-ray, and now we're using cone beam. So we've adapted his process. I think over time, now that we're using cone beam and 3D analysis, that you'll see some changes in how things work. In fact, some of them have already crept in, but we're going to do more testing on that. But this is not a a tutorial on how to use a program. I'm using Horos, H-O-R-O-S. It's the program for the Mac. It's free. I think you have to pay a few bucks to make it the diagnostic edition. And so it doesn't have the little words down at the bottom that says not for diagnostic use. But other than that, it's free. I think it's open source. So you get what you get. It is a good program. The one that most of my friends use is Carestream 3D. Carestream 3D is also a free program. It is made by one of the companies that makes cone beam machines, but you can get it at no charge. It's a very good program, has very good 3D effects. We don't analyze based on the 3D. We look at the MPR or the sliced version, but it's very nice to be able to overview things, which is what we're going to do here first in a minute. That's the one that most people use for PC. There's other programs out there. You have to learn how to do these things with your own program. So there is, in the beginning, when you're first analyzing cone beams, there is a learning curve. It can take a while before you get comfortable with it, and you sweat a little bit. There's tutorials out there, but sometimes it just takes manipulating it like anything else to learn how to do it. So the second thing that this is not a pathology tutorial. Obviously, if you're going to do cone beam analysis, you need to have a report, whether you send it off to a radiologist or not. Now I have two reports. I send it off to a radiologist. I get the path report back. Okay, it tells me about the lordosis. It tells me about, where all the osteophytes are, blah, 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 if there's anything worse. But I also have my own report, but it's when it comes to pathology, it's what I'm seeing, but I'm not too worried because I know I'm going to get the radiologist report. And I'll see things a little differently than the radiologist, but between the two of us, we get everything covered. And I can just do my biomechanical analysis, my articular analysis, and not have to worry too much about anything I might not be seeing. But anyway, so this is not a pathology tutorial. This is not a program tutorial. This is the how to look at a cone beam CT scan and get some useful information out of that, either just how the bones have moved or how they've moved and how to move them back into place. And we find that information much more in the Blair seminars, which I do teach. I've stopped teaching the individual seminars. Now we do intensives, which are 3.5 days. So instead of 3 1.5 day seminars, it's 3.5, one 3.5 day seminar. We do them here in my office in Lubbock, as well as other parts around the United States and the world. This year, I've got 2 in Lubbock, 1 in April, 1 in October, and we're doing 1 in Sweden and 1 in Belgium. Both of those are in November. Um, and if you're somewhere else and you want me to come teach at your place, let's talk. We can work that out. You can find the details on blairtechnique.com. I think it's either blairtechnique.com or blairchiropractic.com. I can never remember. It's the Blair Society's website, and it's got all the seminars on it. Okay, so here we are. We're looking at the 3D version. Now, I look at this one first, not to, as I said before, not to do the analysis. Sometimes, like this one, edges aren't super sharp. This was a very thick 45-year-old male, not obese, but lots of muscle and just built wide. And so the quality of the 3D isn't, I don't think it's diagnostic quality. I can't see anything clear enough to see about the edges that I'm interested in. However, I do like overlooking it. I like looking at the styloid processes, how close they are to the transverse processes of C1, looking at the arthritic changes, like you can see here between C2 and 3 on the left facet. Overall things that you just might need to know and get an overview. And then we can look straight down the middle and we can see the foramen magnum, the ring of C1, we can see the dens, and just see things look a little bit misaligned. It's not enough to give you, in most cases, some diagnostic information. However, it's good because you may say, wait a minute, I thought I saw something on 3D. Did I not see that when I was looking at the NPR version? Again, you can see some arthritic changes over here. And for what it's worth, clinical pearl or not, what I found is that a lot of times the degenerative joints are not the ones that are problematic. They're the ones that are compensating more. They're moving more. And so the body is having to adapt there. They're wearing out because they're accommodating to something else. But that's not always true, but it's just kind of something to think about. All right, so that's a 3D version. I am going to change to the NPR version where we actually do all our work. All right, this is the NPR, multi-planar resolution. It's basically your slices, okay? And your different machines will slice things a little bit differently. The smaller the slice, the higher the detail. However, there is a minimum that you should look at according to the radiologist, and that's about a 3 millimeter slice. This particular machine that I have goes to 0.3 millimeters. So usually before I analyze it, I will find where I'm going to change that and change it to 3. I variously will look at slices anywhere from 20 millimeters, 10, 5, 3. Those are kind of and the 5 and the 3, I don't usually do both of them. I'll do one or the other. Okay, so we're looking at the side view, top, down, and back. Now this particular program will automatically format it like a medical doctor wants to look at it with a side view, a bottom to top, and a front to back. So the left and the right would be reversed. So you'll notice that in my case, I have switched those around before we got online. Left is on the left, right is on the right. Like I've been looking at these since chiropractic college. So that's just the most useful for me. Good friend in Belgium prefers to look at them as a medical doctor, and he talks to more medical doctors than I do. And so then he can just throw that up on the screen without having to adapt it. Okay, the first thing I did before we got on is I found my my reference points. So in the Blair system right now, for good or bad, we use the ground as the level. So when we're measuring our angles, the ground is level. And we use the ear canals, and that stems from using plain film radiography in order to see where the ears were on an X-ray, digital or plain film. We used lead ear markers so we could see that, and then we had an outside reference for inside structures. We draw a line in between. You see this blue line here. And we use that to construct our central skull line. So this brings up an interesting point. For this particular guy, the way he's made, this is not a central skull line. So is it his ears on level? Is it the calvarium? Is it the face? I find this very often, that the face and the calvarium, or the rest of the skull and the facial bones, are often not lined up. So you have to be careful what you're going to be using. Ear canal seems to be the best when you put the patient down, if you're going to be using these angles for your adjustment. If you're just trying to find out which direction the bone is moved, maybe not quite so important. You're just going to be looking at the joints. But if you're going to use angles off of these CT scans, then you need to have some reference points, and you need to have an external reference, because when you walk up to the patient, they're laying on your adjusting table and you're using your protractor or whatever else you're going to be using to measure how you're going to address that joint, it needs to mean something. Okay. I mean, if you're sloppy, you can take a measurement off, walk up, and it has nothing to do with how they're made inside because you don't have any reference points. So this is how the Blair uses it. The Blair system uses it. We're still using the ear canals, even though with cone beam we don't need that. That may change in the future. I wouldn't be surprised. But right now it works. It works well. I have done in my practice, I use the hard pallet for this line because I can walk up to the patient and the line between where the ear attaches and the corner of the eye is typically fairly parallel to that line. So I use that and I line up my protractor with that when I walk up to the patient. It's a little more complicated, but either way, this is going to work well with the Blair adjustment. So first thing I did was line up my line so I can take some measurements. Now, the first thing we do in the Blair system is we look at the atlas. We want to analyze the angle that the atlanto-occipital joints are angled in at. So in other words, they're sitting like this in you, but they're angled inward. So when you're looking at it from top down or bottom up, they're angled in, and these are ellipsoidal joints. And the primary motion of an ellipsoidal joint is to move forward along its long axis. Now you've got two of them paired, and they're not lined up in the same direction, so they're going to check each other. If they misalign, then you know there's a problem. They're made to check each other, but they check each other with soft tissue. It's the ligaments, the capsular ligaments around each joint. And so in an accident, in a trauma, they can be injured and they can go too far forward on the right side, which would make the left side move off of where it's supposed to be. That's where you would see the misalignment. Even the whole bone is misaligned with the bottom of the skull. And with Blair, we're analyzing, when we say a C1 misalignment, we are talking about C1 in relationship to the occiput. When we talk about C2 misalignments, we're talking about C2 in relationship to C3 and everything below. Yes, we are ignoring the AA joint, atlantoaxial joint, almost all the time, not always, but almost all the time. We found that to be a compensation to either C1 misaligned with the skull or C2 misaligned with C3. But it's good to take into account. That's something we're finding with the cone beam. All right, so how do we analyze that AO joint, the atlanto-occipital joint? We're going to scroll down, and I'm just going to bring this closer so that y'all can see. So we can see the lateral masses. Now, I'm going to bump this up to a 10 millimeter. All right. And so I've got the field of view over here. The middle field of view is deep enough. You can see here that the whole joint is fitting inside that view on the left side and on the right side. So we need to analyze this joint. Now, the other thing we need to do is, in order to make this sharp and clear, we're going to come in along the AP plane line. So I'm going to angle this one. Now you'll notice that when I come back to make measurements, now I've moved something. And so I will need to go back to our starting point when I start taking measurements, except for this one here, because moving this up and down isn't going to change what's going on here. We'll talk a little bit more about that later. So right now, I'm still, if I come up just a hair more, I'm getting both joints in there. So let's bring this in closer. I'm going to get rid of the crosshairs there for now. So what we're going to do is we're going to find the long axis of each of these joints. And Dr. Blair has come up with a procedure for doing so using plain film x-ray based on what can easily be seen on most patients, maybe not always easily, but can consistently be found on most patients. Because we cannot clearly see the joints on an x-ray, he developed it this way. We're finding some other points so that we can get close to what that long axis is, and we'll see why we need that in a moment. But what he did first is he found the anterior arch, and he came over here to where it meets the lateral mass on each side, and there's kind of a notch. There's not a clearly defined notch on this gentleman, but he would find the notch, and then he would come back here where the posterior arch would run into the lateral mass. Now, he actually used the foramen magnum, the big hole in the bottom of the skull, where it would cross. It usually would be fairly close to where the posterior arch would. But what we found with a cone beam is if I was going to expand this slice large enough to see the foramen magnum, we would lose a lot of definition. And so things just start to get more difficult. And we found that he allowed this in certain cases, and we found that most of the time it works just great. So that's what we're going to use. We're going to use anterior point 1, which is here, the notch between the anterior arch and the lateral mass on each side, and the posterior point 1, which is there. Now I'm going to switch my tool to the angle tool. I'm going to put a mark there, a mark there, and we're going to come out a straight 90 degrees to that. Okay, 94, pretty close. Let's get that a little bit closer. That's going to be pretty close. Okay, now we need to find a 90-degree angle to this one here, out to the lateral margin of the lateral mass. So we're going to make another angle. Okay, now we are going to bisect these two lines and then draw a line there. So the line that we're trying to create is going to be the convergence angle, or the calculated convergence angle, for the right atlanto-occipital joint. Now, typically, a lot of people will just eyeball this, and we can get pretty close by eyeballing it. But let's just be a little bit more precise for the sake of learning and actually measure this line. This line is about 8.5 millimeters. So we're looking at a 4.25 millimeters to be halfway. And you'll notice that my line stops just a little bit to the side of that line, and that's just so that I can see it later. If it was right on top, it gets hard to see when it's right. Two lines are right on top of each other. Same thing here. Let's do this one. Oh. 1.2, so about 6 millimeters is about halfway. Oh, okay. So I bisected those two lines. Now we're going to draw a line in between. What I'm going to do first for this particular program, when I start moving around, these lines are going to disappear. So that I can come back to it later if need be, this particular tool is going to give me, these dots are going to stay in three-dimensional space. It doesn't matter how I rotate or turn. Okay, let's go ahead. So we come back here. Now remember, as I moved this up and down, this did not rotate at all. So if I use this as my central line, and these are parallel lines, I'm going to measure this angle to that one. So we're going to come back up here. Now measuring this angle exactly is only useful, well, it's got a couple of uses. One of the uses, the most important for us right now, is to be able to find the right spot on this joint to see where it's lined up or not lined up, because not every spot is going to be lined up naturally. Even if the person has totally never had an injury and they are do not have a subluxation by anyone's definition between C1 and 0, there is going to be some areas that do not line up because the joints are not mirror images around all the edges. It's only on the outside lateral margin parallel to this convergence angle. Now, Dr. Blair used x-rays, but he also went and he looked at lots and lots and lots of dry specimens skulls with the atlas and measured and looked and saw where is the area that is most likely going to be lined up, where we can see the misalignment if it is not lined up. So this particular guy, I'll write this down in my notes because I'll use it for other types of analysis later. 25.2 degrees convergence on the right joint. Normal is 18 to 33. He's falling within the normal range. Okay, let's do the same thing. I'm just going to do it faster without so much talking since you've already seen it. Anterior point 1, posterior point 1, 90 degrees. Posterior point 1, anterior point 1. And there is a function here to ask questions. There's also one for comments. Nobody's ever used that, so I hope you can have that. I also tried to set the settings. Maybe that's what messed us up earlier, but probably not, for you to verbally ask questions as well. So look for that option, and we can maybe do it verbally. But you can ask. Let's see, that wasn't what I wanted. For this side, I am going to, since you saw the official way to do it, to be super careful over here, and just in the interest of time, going to eyeball the center there. Now we're going to come back, get our angle. Okay, so now I've got both angles. With this particular program, if you hold down the shift key and click on two different things, then they'll both stay up on the screen while you take your screenshot or write down your numbers. 22.25, so 22.3 and 25.2, fairly close. This guy's almost symmetrical. I've never met anybody or analyzed anybody who's been 100% symmetrical in all areas. Every once in a while, I'll find somebody where the calculated angles are the same. But this guy, fairly symmetrical in his convergence angles. So great, we've got our convergence angles. Now what? Now, so far, that hasn't told us what's wrong. If anything, hopefully by the time you take a cone beam, you've already determined that there is something wrong that you can help. The next thing we're going to do is we're going to analyze these two joints to see if they're lined up properly. And what we want to do is we want to look at this lateral margin parallel to this convergence angle. And I'm going to want to measure it as well. So if I'm going to measure it, then I need to reset the program so that I'm measuring it towards the ground. So now we're reset towards the ground. We can go back down. We can see my dots still there. See, now all my lines have disappeared. Not all programs work that way. So you don't have to do that for everyone, but this one particularly does. So what we're going to do is we're going to line up our crosshairs with that convergence angle. We're going to start with the left side. And the spot the furthest away from the center line here is the spot we want to look at. And typically that's going to be a little bit anterior to the vertebral foramen. So if I scroll down, you can see that vertebral foramen right there. Now we're not looking at the joint anymore, we're quite a bit lower, but you can see that vertebral foramen, and you can still kind of see it there when I come up. We're looking, and we're over here, you can see that I've got the whole joint, or most of it, at 10 millimeters still within my box. We can move that up a little bit if we want, just to kind of say we've got most of it. We're going to want to look at this lateral margin here. Now, it's not really clear in this spot. So there's a couple different things that we can do. Oh, I want to measure it first. Now that I've got everything lined up perfectly. So before I start moving things around to clarify, I'm going to measure the slope angle. That's this one compared to the ground. Or if you're like me, I would be comparing it to the hard pallet line. We're going to measure the occiput, not the atlas. Now, you might say, well, that's about the same. Well, sometimes it's a little bit different, and we're trying to adjust the atlas to the occiput. So the occiput is our reference point. So I'm measuring the occiput. I'm going to move it off the joint a little bit. So when I take a screenshot, it's not on top of there. It's just my particular process. Let's bring back the lines, and we'll see that I'm not quite, my guesstimate of level wasn't quite true. There we go. So this guy's got a 28.4 degree left slope angle. For a Blair doctor, that's important. We'll use that to set up when we're trying to correct the joint if we need it. Over here, we're looking at the convergence angle on the same joint. Now, in the plain film, you'd be looking at this part over here that's off screen. That would be the convergent, or the convexity angle. The convexity angle of the left joint, of the right joint, and you would measure that. In this case, with cone beam, we can see, you know, in one position, all the angles for that particular joint. You've got your convergence angle, your slope angle, and your convexity angle. Now, the convexity is the whole semicircle of the joint, but we want the posterior 1/3. That's the part that's going to be important for adjusting. All right, again, I'm measuring the skull side. I'm going to make sure that my line is level with my reference line. Here we have it. We've got a convexity on the left side. We've already saw the convergence angle. We've got the convexity of 28.8 or 28.9 or 29. I like to go to the 10th. It's probably not necessary. Just round up to the nearest degree. Degrees are so small. Here's a 28.4 or 28 degrees. I would write that down. Now, before I try to determine if things are lined up in this little mess right here, I'm going to go ahead and do the other side. How you decide you want to do it, it doesn't really matter. The idea is you just make sure that when you're actually taking the measurements, they mean something, that they're square to your reference angles. So since I did not move this one, and as soon as you start rotating things, if you rotate more than one thing, then all your measurements are going to be off. If you rotate only one thing, then the measurements would be off on that one. Obviously, I wouldn't want to measure the convergence angle when I've rotated this, because then I would say, oh, the convergence angle is 0. That's not my reference point in this plane, but it didn't mess up these two other planes over here. So what we're going to do is we're going to come back, we're going to scoot back until we're at the thickest part of the joint, at the lateral margin there. I can see the convexity on the right and the slope on the right joint. Left frame, this is the right joint. Good. Let's measure that. Posterior 1/3 of the convexity. (31 degrees). Let's move over here. And 34 degrees. Okay, I've got all my angles. Now I know how to line up my arms. I know how to approach the patient when I adjust them. I don't know what's misaligned yet. We haven't looked at that. So let's do that now. Now that I've got my measurements, I can start rotating things to get a little bit clearer picture. Now remember, we're at 10 millimeters. We don't always get the most clear picture at that. Sometimes I'll move it to 20 if I want to look at the whole joint. It's about 20 millimeters for most people, from the front, very front of the joint to the very back of the joint. But what I'm going to do is, let's get rid of this. Let's get rid of that. So we can see this outside edge. Now, it looks like the outside margin of the skull and the outside margin of the atlas are not quite lined up. Now, we're measuring in reference to the 90 degrees to the joint line, not 90 degrees to the ground. Then you might look like this one is a little bit further to the right than this one if you're looking to the ground. But let's actually use, I don't typically put this in here, but let's say, let's measure 90 degrees parallel to that. It's going to be about right there. Okay, you can definitely see that the outside edge of C1 and the outside edge of C2 are not lined up. Now it's a little fuzzy, so I like to clarify this a little bit more, and we can. But my first thought is, oh, that bone has moved backwards and to the left. It's what we call an underlap. Atlas is a little bit more medial. The lateral margin of atlas is a little bit more medial, so we can tell that the side of laterality is the left. It's moved to the left. The right side is not lined up. Atlas has moved to the left in relationship to the skull. Okay, but let's see if we can get a little bit clearer picture here. First thing I'm going to do, without changing the thickness of the slice, is rotate this so that I can see over here on the left the actual joint a little bit clearer. Now I'm going to get rid of this so we can see our edges better. And then I'm going to change this, so now that this line here, here's the curvature of the joint, and I'm coming in parallel to that point right there. A tangential line, I believe it's called in geometry. Got a little bit clearer over here, didn't it? So typically I would circle this, screenshot it, put it in my report. However, let's see if we can get a bit clearer. Let's see what happens when we change. Let's go a little bit less clear. Let's look at the whole joint and see if maybe we're not looking at exactly the right spot. If we do 20, all right, good. Still looks like an underlap here if you draw a line 90 degrees to that joint. Okay, so now I'm looking at the whole joint, and this would be how Dr. Blair's looking at it. Of course, he's looking through the jaw and everything else, but it looks like an underlap. So I'm pretty sure it's a PIL, but like I said, we can actually make it clearer. The problem is the thinner the slice, the more careful you have to be that you're in the right place. Let's go down to 3 millimeters. What radiologists tell me is the smallest measurement, smallest slice you want to get a clear picture. Start seeing too many imperfections. All right, and we're going to make sure that over here we're still balanced. Here it's kind of hard to see where we are in the joint. There we go. Let's see. So I'm going to make sure that we're actually in the joint before I get rid of that. So it looks like a much clearer picture. And this is probably the one I would take for the report. It's just super clear. I'm pretty sure I'm in the right spot. Now, if I'm unsure, I can move back and forth. Okay. I can make sure it's parallel to the joint surface. As long as I know where in parallel to this line is furthest away, I can go to that joint surface and I can change that around a little bit. And you can see that as you move around, if you're not looking in the right spot, you're going to see that it's parallel, that they're lined up properly, or they look like they are. So you have to make sure. So we go through this whole process to make sure that we're looking at the right part of the joint. If we go too far forward in the joint, look, it looks lined up. And often, if it is actually lined up, it's going to look like an overlap when you go too far forward. The front of the joint is larger on the atlas, is often larger than the condyle. So it will overlap on the front bit just naturally as it's rolling back and forth underneath the skull, or the skull is rolling back and forth underneath it. That's just how the joint is made. The front is larger. So if you look at that, you're going to always think, no, you're probably just not going to be sure of what's going on there. So we don't look at that point. We look at the lateral margin that's the furthest away, parallel, not just lateral, not straight lateral, it's lateral anterior, but we find that convergence angle, and then we go out laterally from that to the furthest point, and we look at that margin right there. So then if I have to go to a smaller and smaller slice angle, I can be pretty sure I'm right. So we're going to call this a PIL in the Blair system. We're going to do the same thing on the other side, but before I do that, any questions on this process so far? We've got one listing. Hopefully we find that the atlas is in juxtaposition or even on the other side, but you can have multiple, you have two joints. You can be misaligned on both joints. It can happen in one accident, but there's no rule that says people can have only one trauma, so that you can have multiple injuries in the joint, even ones that are opposite. They just won't show up at the same time unless the atlas breaks, in which case, hopefully they're not in your office. Or if they are, you send them out. No questions on this? Okay. Let's go back. We've already gotten the convergence angle on the other side. We just need to get back to it. Since we already measured, this is just going to look kind of like wild and crazy, but we're going to go back to that other side and then just line ourselves up with the joint. So you can see I'm parallel to there. Now I'm still at the 5, so I'm going to go back out, or I'm at 3. I'm going to go back out to 10. Seems like a good place to start in most cases. Make sure that my center lines are lined up. We're still looking good here. You can see this outside edge is here. We're looking pretty parallel to that line there. Let's just make sure that we're still looking straight down the joint there. See, look here, outside edge, further out, further forward on atlas to the skull. All right, so we're going to look there, look here. Not real clear, is it? I mean, that could be an overlap. We could have the bone has moved to the left on both joints. So we call that a bilateral misalignment. So it's off to the left. If this is out here to the left further than the skull, it's still off to the left, but it's a little bit different. It's an overlap, but it's not clear. It's not clear. So, oh, look at that. Okay, so we come up to there. Now, if we look at that, that looks pretty even. We're looking at the skull coming down, that there, but let's go down to the 3 and see what we can see. All right, let's see. Let's just get all our lines in the right spot. It tends to want to move around a bit. Good, good. Tangential to that line. I'm gonna say this outside margin, the joint surface seems to end right there, and the joint surface seems a fairly clear corner here. Sometimes we'll find that things are rounded off a bit. It's harder to see, and sometimes you have to take a more general view, which would be like the 20mm one. But it looks like it's level. Let's go out here and just rotate a little bit. Okay, still looking level. So even though at the thicker version, it gave the hint of being further off to the left, we were just seeing a part that wasn't in the right window. So here we are in the correct window, seeing it misaligned. So take a circle of that, take a picture of that, and put that in the report. Even on the left, underlap on the right. So the left side is the sliding joint. In other words, it stayed on track here. It's moved too far backwards on this side, but it caused the other side to misalign. So we're seeing the misalignment on the right joint that tells us that the whole bone has moved backwards and to the left. Okay, so if that is something that confuses you still, the Blair theory of misalignment and how things have moved based on the shape of the joint, love to talk to you about that more. Come to my seminar, send me a private message. We can talk about it. I love talking about it. But that's what we would analyze. This bone has moved, atlas has moved backwards and to the left in relationship to the skull. Okay, great. Now we've got an atlas misalignment. Do they have any misalignments lower than atlas? Let's talk about that. We've got about 14 minutes to do this. So let's get that. This keeps going back to some kind of funny mode, but let's get back to, I'm going to go to 10. All right. These particular joints we measure to the ground. So I'm just going to leave this there. We're going to go look at C23. There's the joint. There's the joint. There's the joint. Okay. And the first thing before analyzing it, just because everything is still lined up, I'm going to measure it. So in case I do have to adjust it, I go ahead and I measure everything, even if I don't see a misalignment at that level, because who knows what's going to happen in the future, and at least we have the measurements. Okay. I just took a shortcut. I shouldn't have done that because some cone beams do not cut off level to the ground. My particular one does. Some are more in a cone shape. So really what I should be doing is lining it up with this. And now I'm measuring C3 because if C2 is misaligned, typically, conventionally, we talk about C2 being misaligned to the segment below C3. So C3 is our reference point, and we're going to adjust C2 to C3. So that's why I measured the C3 side of the joint. Does it make a big of a difference? Not in this case. In some cases it will, but let's just try to be as accurate as possible. There's going to be enough inaccuracies in the whole system as it is. But you can see his, compared to the ground, C2-3 on the left is angled at 48 degrees anterior superiorly. Okay, we'll measure this one down here too. I'm just going to do a copy paste so that I don't have to re-measure to the ground. Boom. Shift and select, and I can take my picture. I've got the two measurements, C2 to 3, C3 to 4. Now, we didn't get very low on this guy. He's got really big shoulders that they didn't, I went down as low as I could so that the machine, as it rotated, didn't smack into his shoulder. But so that's as far as we got. Fortunately, the most important subluxations in the cervical spine are usually between C1 and between the skull and C4. So we didn't see C4 on 5 here, but we're getting the 2 on 3 and the 1 to the skull, which are by far the most important. And we can kind of, if we figure out that there is a misalignment between C4 on 5 or 5 on 6, we can kind of extrapolate from these angles where to come in and do a more ballpark measurement. All right, so that's how I measure it. Let's go analyze that. What I'm going to do, there we are, is now I'm going to line this up with the joint. Good. And up with the joint over here. So you can see if they had a little tropism. Most people do. This guy doesn't. He's hardly got any tropism between C2 and 3. That's odd. Everybody's different. Okay. Now the 10 millimeter is pretty much most of the joint. So, and it looks like there's some arthritis going on here. Was this the one that one of the ones we saw on the 3D? We could go back to that and look at it. But let's go down to the 3 millimeters again. And oh yeah, this is the joint that this is one of the two joints that had lots of degeneration. It's going to be hard to see how it's misaligned. Like I've said, often the ones that where it's really hard to see because of degeneration, my experience is that that's not one of the primary problems. But let's just look at it. I want to do my due diligence. I'm going to run back and forth. Now, what are we looking at here? That is a total mess. Okay, I mean, we've got this little lip down here at the bottom. We've got stuff going on up there. This one's super difficult. What we're trying to determine is the anterior margin of the inferior facet of C2. Does it line up with the superior facet of C3? Now, so we're looking at the hardened joint surface on each side, and this one is just really hard to see. Maybe it's here, maybe it's here, maybe it's anterior. Really hard to see. Down here, if we look at C3 on 4, line it all up. This one's going to be a little bit easier. Now the back looks bigger. It looks like it's gone posterior, but that part often does. So we, again, like the atlas, there's certain parts of the joints that should line up if everything's okay, and certain parts that just naturally don't. Okay. We're getting medium. So really with the C2 on 3, what we want to see is this anterior margin, which is going to be way up here. We can kind of wiggle this back and forth, and it looks like maybe here is part of it, and then that would be anterior. So if we go through here and we determine that that is actually the anterior margin of the joint, then it would have slipped up and forward in comparison to C3. We would call this an ALS. It's on the left side. It's on anterior and superior. Actually, the L doesn't tell us the side of the joint, although in this case it coincides. It tells us the laterality. So if the neural canal has gone forward and up on the left side, the whole neural canal has rotated up and forward towards the left. So the side of laterality is left. Just so happens that when we list it ALS, it's also the side of the slipped joint. It's different when we go posterior. So if it had gone posterior on the left, the whole neural canal would have rotated down and to the right. So we call that a PRI. Confusing in the beginning, makes sense later if you think about how the neural canal moves, but it's always been kind of a source of irritation to me that it's not named on the joint that's misaligned. Okay, so that's how we analyze C2. Now we've got 8 minutes left, so let me just talk a little bit about what if you can't see this clearly? What other things can you look at? You can look at the posterior. Like I said, in a lot of people, that's going to be, even if everything's lined up perfectly, that's not going to be lined up very well. You can look for the joint. If there's an anterior margin, if there's an anterior wedge in the joint, often that means it's gone posterior. Well, in this case, there's an anterior margin, but it looks like it's gone anterior. I mean, an anterior wedge. So we're going to get all the, if we can't see the gold standard, we're going to kind of take our clues from other things. The next one is looking at the parasagittal George's line. So if you remember, George's line is when you're looking at a lateral, full thickness, and you draw a line down the back of the bodies, they should all line up, right? Otherwise, you're thinking anterolisthesis or posterolisthesis. It's slid forward or backward. Like, look, this one looks like it's gone a little bit forward compared to C3, but C3 on 4 looks nice and even. Now, sometimes, depending on the angle of the C2, C3 joint, it can be misaligned, and this still looks even. It hasn't moved the needle so much on that. So again, you can look at the posterior margin of the joint. You can look at the wedging of the joint. You can look at the parasagittal line. You can also look at, and let's kind of reset here. Look at the discs. Are they wedging? Is there a wedging? Is there a bigger space between C2 and 3? That means, hey, if the space is larger here, maybe this one is dropped down and back, and so it's increased here than here. Those are pretty level to me, so it's not giving us any clues whatsoever. Same thing with the wedging. If C2 has gone up and forward on C3, then you might possibly see an open wedge over here as that opens up. Or if it's gone posterior and inferior on C3, then it might be squishing down here and you have an open wedge on this side. So the open wedge you're going to see on the side of laterality, potentially. There's a lot of factors. This is more complicated than we know, finding out. So these rules we put into the Blair technique are the ones that, hey, this is almost always true. These other things kind of gives us clues. The other thing is you can do a neural canal study. So we can actually just kind of move up and down the neural canal and see if one of the bones rotates. If it rotates, then we have to determine, is that because of the way they're shaped, or is it because of a misalignment on the left or on the right? So sometimes if you have a misalignment on both sides, it's not going to rotate and it'll have moved forward on both sides. So here we're looking at C2. It looks like it's rotated forward on the left or backwards on the right compared to C3. If you look at the posterior body, let's go back down here. Okay, pretty level. Pretty level. So C3 and C4 don't seem to be rotated in relationship to each other, at least not enough to show up here. A C2 on 3, there's a rotation there. So now I'm thinking, okay, let's go look. We looked at the left. That was a mess. Let's see if it's gone posterior on the right. And since we've got a minute or two left, let's go ahead and do that. There's a little bit of tropism there, right along the joint there. Let's see, was it this one? There we go. Okay, let's get rid of that so we can see. Now you notice I'm at 0.3. So let's get that to 3 millimeters. Get it out of this other mode. Not clear. So we have a couple of clues on the left side that make it look like the left side. As far as the gold standards go, neither side is clear. Looks like it's lined up. It's not obviously inferior or anterior. No wedging of the joint. Posterior looks lined up. We go to the lateral margin here, it looks lined up. So we're not finding any clues on the right side that it's misaligned. When we go to the left side, we're finding maybe some different clues, but it's just messed up because of all the degeneration. So maybe it's a compensation for the C1, C2 joint, or C1, C0 joint being misaligned and causing some abnormal motion here. We don't have great reading on this one, but we've got clues. One clue that looked like maybe it had gone forward when we were looking at that anterior margin, a couple of them that looked like it had gone posterior. We had the anterior wedge, which isn't showing up real clear on this one, on this picture now, that would seem to indicate it had gone posterior. So we're getting conflicting, not a clear answer. So typically I'll leave those alone, unless in my exam I'm pretty sure that it's misaligned, and then I'll maybe come back and look at this again or determine from the exam. All right, so and we'll just go down. I'll measure every joint that I can see. I'll look at every joint that I can see, C2 on 3, C3 on 4, 4 on 5, if I can get down that low. I'll run up and down using the neural canal analysis. I'll also look at what C2 is doing on C3. There's been a few cases where I felt like that was what needed to be adjusted. See here, it looks like the posterior margin is a little bit further back, but it's pretty close. Anterior margin often I find doesn't line up. It's kind of the same thing. We have to find where on the joint, when everything is normal, should it line up? And my theory is that where the neural canal is, those should line up. The posterior margin of C1 and C2, lateral mass of C1 and the body of C2 should line up. As we move towards the middle, they do line up. We move to the other side, and we're seeing a very small anteriority of C1 on C2 right there. So that's probably not significant in his case, but I'll write it down because since in the Blair technique, I can choose which side, regardless of laterality, which side I'm going to adjust from and just adapt my contact point. Maybe I'll want to make sure I don't push this one a little bit further forward, and I'll choose a different contact point. But okay, let me have it. Questions? How are things going? Need any more information? We're done for today. February's, we're not going to have any more in January. I'm going to be at Sherman College. We're going to do this again, and I'll send it out, but I think the next one is February 10th. I think there's 3 weeks in a row, February 10th, 17th, and whatever the next one is after that, 21st. Any questions, comments, something you would prefer to see? We are done for today. I'm going to hang out here for a couple more minutes if somebody wants to ask, but you can email me, text me. 2 questions just showed up. Oh, one was a thanks. And, oh, Kobe, great. Oh, you know what? Some of these questions showed up in, okay, Ryan. Sometimes the 3D on ours doesn't end up this crisp. I found it typically older people or people that are heavier set. Is there a setting on taking the CBCT that can change that? I've tried some experimenting with changing the voxel. So there is different sizes. Voxel is the 3D pixel that we measure the slices in. And you can change that. I try to get as detailed as possible. And the machine kind of like a lot of the digital x-rays, the machine kind of picks the best one, especially if it's designed that way. Because we're not using the 3D for the analysis, I don't worry about it that much. So I haven't played with that. I'm much more interested in get a clear, crisp picture on the MPRs, but even then it is hard with the, it can be hard with a thicker person. It just gets a little fuzzier. Kobe, what's your general time to analyze? I've spent 30 minutes to over 1 hour. When I first started, I would spend over 1 hour and have a very simple analysis. Now I typically spend 50 to 60 minutes, but it's because I'm still experimenting and I'm still looking at things. If I wanted to get a really quick measurement and analysis of the joints, I could probably do it in 15 or 20 minutes now at this point. But again, I still take about an hour just because I'm looking at a lot of other measurements and trying to correlate them and come up with some better systems. Let's see. Kobe, I would love to see how you capture video synopsis of the 3D view in MPR at a later time. Okay. Oh, well, it depends on the program. In the 3D, when you're looking at it with 3D, there is a way to export it with movie. But what I did was I just took a screen video clip, and it's easy with a Mac. I don't remember exactly. I know it's possible also with a PC. I don't remember exactly how to do that. But I don't mind kind of going over that with you later. So, all right. Any other questions? Kobe, we should just get together sometime. Hiroki, thanks for coming. It's rather early in Japan. Hope you do well. And you can always get the videos of this um, online. I mean, you'll get an email that has a video of this. So I know a lot of people sign up just for that opportunity. I'll talk to you guys later.